I'm Jodi, Rubin, allergist and immunologist. Two things you should know about me. Number one, yes, I went to University of Michigan. I'm a die-hard Michigan Wolverines football fan. Go Blue, they're number 5 in the nation right now, and I would not probably have accepted Dr. Real's invitation for me to be here today, but it's a bye week. So, oh, and by the way, Bucks are number 12. And you can't spell Urban Meyer without U and M, so. Anyway, the other thing that you should know about me is I'm obsessed with Bruce Springsteen. I'm talking about allergic rhinitis, we're talking about the nose, and baby, we were not born to run. So, the boss. Okay, now we'll start off, obviously allergic rhinitis. Talking about rhinitis in general is inflammation of the nasal mucosa. When we're talking about allergic rhinitis, it's due to the immune system making antibodies, which are IgE antibodies, against harmless substances that we inhale called aeroallergens. It affects 20% of the population. Certain literature will say higher or lower, but roughly around 20% of the population. It results in everything we know, sneezing, all the hay fever, sneezing, rhinorrhea, nasal congestion, nasal itching. It also will involve often the eyes, the ears, the sinuses, the throat, hence why I'm part of Valley ENT. And can affect the entire upper and lower respiratory tract. This was one of the pre-test questions. Allergic rhinitis and asthma frequently coexist in the same patient. So I often see in primary care or even in ENT, we're treating allergies. You've got to think about the entire respiratory system, excuse me, because allergic rhinitis is present in over 80% of patients with asthma. So again, atopic asthma, allergic asthma, extrinsic asthma, whatever you want to call it. Nowadays, we have all these biologics, Xolair, Fasenra, Nucala, Dupixent was just approved last week. These all target different paths of the atopic pathway. And asthma will be seen in 40% of patients with allergies. So allergic people with allergic rhinitis, you can have an allergic march and they might develop inflammation of the lower airway and obstruction, which is asthma. This is very types of allergic and types of rhinitis goes into the allergic and non-allergic category. I tried to just set this up. I'm going to go through this quickly in lieu of time. You have these slides. Allergic is IgE mediated. We call it seasonal or intermittent, perennial or persistent, which is throughout the year. Non-allergic is non-IgE mediated. There's several classes. Vasomotor rhinitis, these are patients that will have rhinitis symptoms due to irritants, whether it's temperature, barometric pressure changes, pollution, smoke, perfumes, fragrances, et cetera. And this could be up to 50% of patients that you see with rhinitis symptoms. Interestingly, in clinical trials, not in practice, they're doing nasal provocation studies where they locally will do nasal allergen provocation to the nose. In those frustrating patients, as an allergist that I see, that either the in vitro RAS test was negative and the skin test was negative, we call them non-allergic rhinitis, but they still have the itchy eyes, they have all the symptoms that are typical of the allergy patient. They're finding that up to 50% of these patients only have local production of IgE in the nasal mucosa. And so that's a new category called local allergic rhinitis. And there's a lot of studies coming out, so that'll be a new category. And then you can have the mixed in the same patient having both the non-allergic and allergic component because they have hyperresponsiveness. Gustatory rhinitis, you often see, you go to a sushi restaurant, you eat wasabi, your nose starts dripping. Some people will drink wine, they get nasal congestion. These are temperature foods, cold and hot temperature foods can cause stimulation and cause rhinitis symptoms. Medications, we see this often, rhinitis medicamentosa. These are patients that are on chronic afrin, chronic topical decongestants. And what you're doing is you're actually vasoconstricting the blood flow to the nose and peripherally, by the way. So think about this in hypertensive patients. But when the medicine wears off 4 hours later, then you get the vasodilation, a rush of blood to the nose, and they'll get the rebound congestion. Also, cocaine use is similar. Hypertensive or antihypertensive medications, beta blockers, ACE inhibitors, that's a side effect is nasal congestion. You got to think about that. Hormonal treatment, hormonal causes such as pregnancy, birth control pills, you might see it in postmenopausal patients. And number one thing I always think about is hypothyroidism, because if you look at a TSH level from LabCorp or SonoraQuest, 0.45 to 4.5 is normal. truthfully, you got to keep that TSH as close to 1.0 as possible in patients that have rhinitis symptoms. So I don't care if it's 3 and you say their levothyroxine is, controlling it, you really should up the dose and get the TSH driven down as close to 1.0 as possible if they have rhinitis, such as chronic nasal congestion. Infections, obviously, viral is number 1, the common colds, rhinovirus. Don't treat with antibiotics, 7 days with, 1 week without, it'll resolve. And finally, I'm not going to go through all these atrophic rhinitis, elderly, you think about sinusitis, obstructive causes such as adenoid hypertrophy, deviated nasal septum, polyps, CSF leak, unilateral rhinorrhea. You should consider that, Wegener's, sarcoidosis, et cetera. So what's the pathophysiology? Obviously, I told you it's due to making the harmless IgE antibodies against inhaled aeroallergens, and it's driven by what we call the Th2 paradigm, which is the type 2 helper T cells. And the aeroallergens are pollens, which is ragweed, weeds, trees, and grasses. Mold spores can do it, dust mites, cockroaches, animal dander, or their pelt. And let me go to the next slide, just fast forward through this. So this is a diagram. You have, here's the pointer, okay. So let's say the allergen is grass pollen. It comes in, this is an antigen presenting cell, let's say it's a dendritic cell. It'll process, an allergen is always a protein, so you can't be allergic to salt, for instance, if you hear people talking about these things. But anyway, you break down the protein into peptides. The dendritic cell will then present the peptides in association with major histocompatibility class 2 complex. You have a naive T helper cell, and in the presence of interleukin-4 and other mediators, but interleukin-4, you will drive this naive T helper cell to become a Th2 cell, which then recognizes the MHC class 2 via its CD4 receptor. It then subsequently produces interleukin-4 and 13, and if you have a B cell, it'll actually cause class switching. The B cell will stop making IgG antibodies, will make a specific IgE to this allergen, and then it'll be free-floating, and it might make its way over to this is a mast cell in the tissue. So you have the high affinity Fc epsilon R1 receptor. These IgE antibodies are like antennas. The next time you inhale this grass pollen, these will recognize that pollen, but you need the pollen to actually cross-link two IgEs. So if it's only here and it doesn't touch two IgEs, the mast cell won't degranulate. Then you get the degranulation of preformed and newly formed mediators, which includes histamine, leukotrienes, prostaglandins. You get the early phase response, which is all the hay fever, itchy nose, sneezing, rhinorrhea, congestion. 4 to 6 hours later, you get influx of eosinophils, basal cells, more Th2 cells. IL-5 is a big driver to get the eosinophil infiltration. And the late phase is usually nasal congestion for hours and hours later. That explains that you have that slide. So allergic rhinitis symptoms: red, itchy, watery eyes, itchy, clogged ears, itchy nose, sneezing, congestion, rhinorrhea, postnasal drainage, sore throat, itchy throat, throat clearing because of the drainage. It's very annoying. Coughing because of the drainage, snoring and mouth breathing because of nasal congestion or associated tonsillar hypertrophy, nasal obstruction, sinus pressure and headaches, and fatigue because of all the congestion, difficulty sleeping, etc. So on physical examination, what are you looking for? Injected eyes. I don't know if this, oh, here it is. Injected eyes, red injected eyes. Ocular discharge. Allergic shiners. So allergic shiners are the dark blue or black discoloration under the eyes. A lot of patients will say they have bags under their eyes because of lack of sleep. It's not due to that. This is venous pooling because your nose is so congested that you get blood pooling right here from the veins. And then going along with that is also these Denny-Morgan lines, which are these creases of the lower lids. Nasal discharge and secretions, boggy or pale blue discoloration of the nasal turbinates on examination, swollen nasal turbinates. You can have associated nasal polyps. And I also love AC/DC. I love rock and roll in general. So allergic crease. For those about to snot, we salute you. That's the allergic crease. If you have the allergic crease, you usually see this in children. Their nose is itchy and runny. They constantly go like this because they're not going to get a tissue. And then they can get the allergic crease, which is that horizontal line. You even see it into adulthood. I pointed out in my patients, they get very self-conscious. I don't mean to do that. Cobblestoning is the streaks in the posterior oropharynx from the drainage. And due to chronic mouth breathing, you can actually get a high arch palate and an overbite. And finally, you can have associated tonsillar hypertrophy. Risk factors, if you're allergic to something, if you have atopy in general, you have eczema, et cetera, you're going to be more likely to have this allergic march. So you go from eczema as a baby, you might develop allergic rhinitis. Again, we talked about asthma, so you get the allergic march again. A family history, strong family history, so parents or siblings with allergies or asthma, having one parent will increase the child's risk by 30 to 50%. If both parents have allergies, it more than doubles the likelihood of the child developing allergies. But I often have patients say to me, well, my mom's allergic to penicillin, so am I. It doesn't get inherited that, yes, the peanut allergy is inherited, or the penicillin or the grass allergy. It just means if you have an atopic family history, you're more likely to develop some sort of allergy. Household pets, growing up with cats and dogs. History of maternal smoking might be due to the inflammation from that. And then there's actually protective risk factors or negative risk factors. For some reason, if you have multiple older siblings, which might be due to exposure to a lot of infections and bacterial, microbial exposure, so that and that's the same with growing up on a farm with exposure to farm animals. This is sort of like sort of like the hygiene hypothesis. So if you get microbial exposures, you shift the immune system away from the Th2 atopic paradigm towards the Th1 paradigm. So complications and comorbid conditions, complications, impaired quality of life, that's the number one thing. They get fatigue, they can't sleep, they can't concentrate. Poor sleep, they can get sleep apnea because you get the nasal turbinate hypertrophy and obstruction. Difficulty focusing, you can't imagine how many patients are diagnosed with ADHD. The children in school, they can't focus, they didn't sleep, they have brain fog from the congestion or the sinus inflammation, and they get put on Ritalin, Adderall, et cetera, and they really don't have ADHD. So you gotta think about allergic rhinitis. Again, that goes along with poor work and school performance and absenteeism. And then the comorbid conditions, allergic conjunctivitis and sinusitis, obviously, nasal polyps, otitis media, eustachian tube dysfunction. Again, we saw from Dr. Imami's talk, the eustachian tubes drain into the nasal passages, atopic dermatitis, and asthma. How do you make the diagnosis? Good history and physical, confirm with allergy testing. You can do the in vitro RAS test. It's not nearly as sensitive. I'm not going to go over how it works, but in your slides, I tell you exactly how this is performed. Refer to me. Refer to an allergist for in vivo skin testing. It's way more sensitive. We do skin testing by both the scratch or prick method, depending on which allergist you send to. And if that's negative, we actually do intradermal skin testing, where we go a little bit deeper under the skin to get the full extent of their allergies. And this is looking for the immediate wheal and flare histamine reaction, so you actually see how allergic they are. Treatment, there's 3 categories. Number 1 is environmental control measures or allergen avoidance. A lot of these are self-explanatory. If you're allergic to, remember, molds can be indoor and outdoors, so indoors and outdoors. So if you're allergic to pollens or outdoor molds, keep the windows closed, limit your outdoor activities. Animals, no one's going to remove their loved ones from their home. So I rarely make people get rid of their cat or dog, but obviously that's the number 1 thing. But if they're not going to remove the cat or dog, try to bathe the dogs regularly, keep them out of the bedroom, vacuum regularly. You can run a HEPA filter, which is a high-efficiency particulate air filter, collects dust mite particles, mold spores, animal dander, et cetera. So dust mites, washing bedding in hot temperature water kills the dust mites. You can get dust mite covers for the pillows and mattress. HEPA filter again, vacuuming, and mold allergy. If it's indoors, you want the humidity in the home less than 50%. They like mold. They like humidity. Pharmacological management we'll touch on, and then immunotherapy. So for medications, the number 1 first-line treatment is topical intranasal corticosteroid sprays. This helps the inflammation, and this will help with every symptom, including allergic conjunctivitis symptoms, and nasal congestion, and obviously you can combine it with other classes. Oral antihistamines nowadays, we usually use the non-sedating 24-hour H1 blockers, Allegra, Zizal, Zyrtec, Claritin, all over the counter. These will help every symptom. They're not doing anything preventative, but they will not help nasal congestion because they have no anti-inflammatory properties. So you have no idea how many patients still come to see me because they've tried every over-the-counter antihistamine. They didn't try a nose spray. Topical intranasal antihistamine sprays. My colleague, Dr. Hurley, loves azolastine or dimista, which is a combination of fluticasone and azolastine. And we also have patenase or olopatadine. Those are great for all symptoms, including nasal congestion. They also work in non-allergic rhinitis. and you can combine them with other medicines, including the intranasal steroids. Leukotriene receptor antagonist, singular. Singular I find very helpful as an add-on. It's going to help control inflammation, and it's very useful in patients that have both upper and lower airway inflammation. So if they have asthma as well, and again, you can combine it with other classes. Decongestants, oral decongestants, Sudafed, and topical intranasal sprays like Afrin. I usually never use these for allergic rhinitis. Yes, for acute sinusitis, if they're flying in an airplane, you use it for a few days. In allergic rhinitis, nowadays with intranasal steroid sprays, there's really no need for these, and they can cause all the side effects of hypertension, elevated heart rate, insomnia, anxiety, and again, we talked about rhinitis medicamentosa or rebound congestion. Topical intranasal anticholinergic sprays, Atrovent or ipratropium bromide, old school medicine, very safe. I find this most helpful for rhinorrhea, so patients that have non-allergic or allergic rhinitis, but their main symptom is rhinorrhea. Topical intranasal mast cell stabilizers, I haven't used these in years, but cromolyn sodium. It's good for prophylaxis, but it does not have any direct anti-inflammatory or antihistaminic effects. Saline nasal irrigations, you're going to rinse out the allergens. You're also going to flush out the mucus. Those are very helpful, natural way to do it. Neti pot or Neilmed bottles. And systemic corticosteroids, oral prednisone or intramuscular Kenalog. I've given absolutely 0 Kenalog injections my whole career. I've been practicing for 20 years. For allergic rhinitis, there is really no reason to give steroids unless you have sinusitis or severe nasal obstruction. Maybe you give a short prednisone course for a few days. Immunotherapy. So we have subcutaneous and sublingual immunotherapy. Obviously, I agree with this. It should be administered by a board-certified trained allergist immunologist. You should consider this if they don't get a lot of relief from the treatment avoidance measures or the medicines, or they don't tolerate the medicines. Also, if asthma is present, this is a very helpful treatment because you're desensitizing them. So you're giving incremental amounts. You're introducing the allergen either subcutaneously, which is the allergy shots, or sublingually until you reach the highest dose, which is maintenance. I offer what's called rapid desensitization protocol, where I'll build up my patients towards the maintenance dosage on their allergy injections within 1 8-hour office visit, because time of coming weekly for 6 to 12 months in some practices, I get them up to maintenance in about a month. It's the only immune modulating therapy. You're actually changing the immune response. You're turning it down, developing tolerance or desensitizing the patient to what they're allergic to by repeat exposure. This works. These are the theories in studies that you increase T regulatory cells, you increase IgG4 while decreasing specific IgE production, and so you're shifting away from that Th2 atopic paradigm towards the Th1 paradigm. Maintenance, usually I would say a minimum of 5 years on allergy injections, and sublingual is saying from 3 to 5 years. And this is the only treatment for allergies that when you discontinue the treatment after the full 5 years, let's say, it's the only treatment that persists, the effect persists after you discontinue. So this is a lifelong immune modulating way to change their allergic response and desensitize them, unlike medicine where they'll have to be on it for the rest of their life. And so sublingual immunotherapy, there's currently only 4 rapidly dissolving sublingual tablets which are FDA approved in the United States, only 4. There's Oralair, which is 5 grass species. You have Grass Tech, which is Timothy grass, Ragwitech, which is ragweed, and Odactra, which is dust mites. I've used these 0 times because my patients are polysensitized. You do have physicians that are making their own sublingual drops using the commercially available subcutaneous immunotherapy extracts. This is not currently FDA approved in the United States, although it's been widely used in Europe for many years. And in the United States, they're still doing the potency and efficacy trials to determine the effectiveness, what amount you're supposed to use, how can you mix these allergens, et cetera. They're doing it at home, so you want to make sure that they're not having anaphylaxis. It is going to probably be approved in the allergy immunology world within the next 1 to 2 years, but I personally don't do this just yet because also without FDA approval, it's fee for service. Insurance will not cover this. It does carry less of a risk of anaphylaxis or systemic allergic reactions than allergy injections. However, they found that a lot of patients actually discontinue sublingual immunotherapy more often than subcutaneous, and this is because of the adverse side effects of local oral itching, or most often it's this GI upset, diarrhea, and then the patients just don't tolerate it. They don't want to do it anymore. It can be taken at home versus allergy injections, which must be given in the doctor's office. But it has to be taken every single day, whereas remember, allergy shots is once a month once you get up to maintenance. So there's pros and cons about both treatments. You just got to think about this. And again, sublingual might not be efficacious if you're allergic to multiple things: cats, dogs, grass, ragweed, dust mites, etc. So key points. It affects 20% of the population, impairs quality of life in many ways, comorbid conditions infecting the entire upper and lower respiratory system, with its linkage to asthma, diagnosis with history of physical, do skin testing either by blood or by or in vivo skin testing. You can avoid allergens or do medication treatment. Refer to the allergist or immunologist for immunotherapy and further management of allergic rhinitis, including its comorbid conditions such as eczema and asthma. And finally, Bruce Springsteen's the best. That's it. Thank you.
Thank you very much.
When you start treating a patient with pharmacological management, because they have, let's say, a seasonal or allergies, how many times would you treat them before we refer to an allergist?
I guess it depends on the patient's comorbid conditions. You know, if they have hypertension or coronary artery disease or other things, you don't want to use decongestants. If they're not responding to the intranasal steroid sprays, if they're having side effects, if the antihistamines are making them drowsy, although we have non-sedating ones. But I would say it really is about the severity. If you just have a person that sniffles every spring, you might not consider a formal allergy immunology evaluation. But if you have a patient with allergic rhinitis, chronic sinusitis, recurrent bronchitis, asthma, I mean, you can't forget, we don't only test for allergies, we test the immune system. So we're looking for immune deficiencies, we get immunoglobulin levels, et cetera. And now there's the biologics. Hopefully, if I'm asked to speak again next year, maybe we'll have these, anti-IL-5 and IgE and anti-IL-4 and 13 approved for allergic rhinitis or at least sinusitis moving forward. So,
But can you just keep them on maintenance treatment?
In terms of medicines?
Yes.
Yes, if they want to stay on medicines for their life and they're responding well, yes, you can.
Is it possible to be allergic to dust, or is that just an irritant?
No.
I'm thinking of living here in the valley.
So dust itself is not an allergen. So an allergen is by definition a protein. Dust is a conglomeration of everything in the air. So you're stirring up the airborne cat or a dog dander, you're stirring up the mold spores, the dust mites. Now remember, dust mites are what you should be testing for. Those are the microscopic insects, and everyone's home, no matter how clean we are, they like carpeting and fabric and bedding, but they'll be in tile floors, et cetera. So, and here in the valley, it's interesting because dust mites usually prefer humid climates, but we do have dust mites in Arizona.
Can you explain how the TSH affects? I'm trying to understand how keeping the TSH.
So the hypothyroidism in general has a lot of ties to atopic conditions or non-atopic conditions. Chronic urticaria actually is not an allergic condition. Uncontrolled hypothyroidism can cause an immune response. So in some patients, they'll get actual nasal congestion, just like they get constipation. It's a function of your underactive thyroid. The problem is the range of what's normal is way too broad. And I'm internal medicine before allergy immunology, so I get very aggressive with my own TSH. I'm on Synthroid. So yes, TSH to 1.0.
Thank you.
That's it. Thank you.
Oh, one more question?
How often are you desensitizing people to medications? Like I did a rotation with you guys, and they were trying to get somebody off desensitized to aspirin because they needed it for other therapies.
So aspirin and penicillin are standardized protocols in allergy immunology. Penicillin desensitization is different than penicillin allergy testing. You have a patient that, say, has neurosyphilis. They're only responsive to penicillin. You put them in the ICU. You actually give them incremental amounts of the beta-lactam while monitoring their vitals. And what you're doing is saturating the IgE receptors. Same thing for aspirin desensitization. If you give them incremental amounts of aspirin over the course, some protocols are 1 day of 8 hours where you're advancing it. A lot of times for safety, if you're doing it in the outpatient office setting, you separate it into 2 days of aspirin desensitization. And if you saturate the IgE receptors, remember you have to cross-link the IgE antibody for the mast cell to degranulate. So if you get aspirin here and aspirin over on another IgE and they're not cross-linking, then the next time aspirin comes in, all those spots on the IgE are taken. So you can't get an allergic reaction, and that's useful in patients with nasal polyps. Anyone else? Yes?
When you just demonstrated the proper use of it, do you let the excess run out?
Yeah, so you're looking down at your toes. I say nose to toes. You point it up and away towards the outer corner of your eye. Do a spray on the right, then the left. Go back and do your second one on the right, second one on the left. Gravity, it's going to drip out. Have a little Kleenex. Don't snort it back. Just sniffle, sniffle, and you're done.
Complain of sore throat, I bet, because
And if they use azolastine, it has a bitter taste. It works amazing. So keep their head down for an additional 10 seconds. Chase it with orange juice or Tito's, and you're good to go. I don't know. Do you need this? Oh, you got it?